Good afternoon. WLBT's Ask the Experts is now live from the Hub. I'm Kelly Boyd. Joining me today is Dr. Jeanann Suggs from Baptist Cancer Center. Welcome to the show.
Thank you. Happy to be here.
Great. We've got lots of great questions from you from our Ask the Experts page on WLBT.com. But while we're live, you can ask Dr. Suggs anything about cancer right here on Facebook. So we're talking about breast cancer today.
Right.
But you treat all types, right?
Right.
Mm-hmm. And you can tell us about your specialty?
Sure. So I'm a radiation oncologist. So if you ever know anybody that's getting cancer treatments and they have surgery and chemo and radiation, those are actually all different types of doctors. So I'm a radiation doctor at Baptist, and so what I do is I treat with radiation some of the tumors that adults have that respond to radiation. But specifically today we'll be talking about breast cancer.
Okay. Great, thank you. And that first question is, what is radiation therapy?
Right, so it's a very good question. A lot of people say, I don't really know. But radiation's it's a high dose energy that we direct to the parts of the body that we want to treat. And it helps to disrupt the way those little bitty cancer and tumor cells, the way that they are able to grow and divide. So we interrupt some of that programming so that whenever they're trying to do like tumors do and grow and divide and multiply, they don't have that instruction manual anymore. So it's kind of exciting, neat little technology that we have.
All right. Next question, is radiation the same thing as chemo?
Right, so those are two different things. So radiation, like surgery, is a local therapy that is directed to a part of the body, and it only affects that one part of the body. Whereas chemotherapy you think of as like a systemic treatment that goes all over the body, either a pill form or an IV form, and it treats anything that may be sort of traveling through the body, any little cells that may be there. And that's a separate specialty. So that's a medical oncologist that prescribes chemotherapy, whereas a radiation oncologist prescribes radiation treatments.
Okay, thank you. So much clarification happening today. So what are the benefits of radiation therapy?
Sure. So radiation is a great treatment, especially for breast cancer in the postoperative setting or even in the palliative or trying to make symptoms better setting, in locally treating where tumor cells may be left behind. It's kind of a package deal with some of the types of breast cancer treatments that we have.
Okay. What is the process and what happens when someone goes through radiation?
Oh, so that's going to be a little bit of a lengthy response.
Sure.
And that's because most people have no idea with radiation therapy. The first thing that they do is they're going to come in for a consultation with me or with one of the medical radiation oncologists. And in that consultation, we're going to talk about why we recommend radiation, what the process is with radiation, and what they can expect and some of the side effects. Because a lot of times people don't know, or they've heard these really horrible stories from people that had radiation years ago. And the nice thing is that times have changed, technology's improved, so some of these are getting much easier than they have been in the past. But so they'll come in for a consultation, and we'll talk about why that we recommend radiation. And if that's something that they decide to go forward with our recommendations, they'll come in for, the next step is usually a planning CT scan, or sometimes it's a clinical setup, but they'll come in for something that we can use their body shape or use some images so that we can actually tailor and direct the radiation to where it needs to go. You know, we talked about it's a local therapy. It doesn't go all over the body, so we want to direct it just to where it wants to go, avoiding all the other important things in the body that we don't want to do.
Right.
So after that's done, we usually have what's then called the planning process. So we actually have a team in a radiation department, not just doctors, nurses, but radiation therapists that run the machine, physics teams that help to maintain the machines and do some of our second checks, and then a team of medical dosimetrists, which are specially trained medical people that go to school so that they can actually take the information of where we want the tumor to be treated and can design radiation beams and angles and depths and all sorts of really scientific and cool stuff so that the person can get the absolute best plan. So we want one that's going to be effective, but that's also going to be safe. So all of those people are working together behind the scenes. So after this person will come for a CT scan to plan the radiation, it may be a week or two before they start because of all that going on in the background.
Wow.
We always want to make sure we're getting our radiation plan great from the get-go because we can't take it back once we give it to you. So we want it to be the best one from the get-go. So after the consultation and they come for the practice run or for the CT scan to do the radiation planning, they'll come in for a practice run. And that's where we verify that what this computer says is supposed to happen in real life is what we actually see in the patient's body. We check depths, we check measurements, we check angles, those sorts of things. And once that's done, the patient's ready to get started with radiation treatment.
Okay. That is awesome. So it's extremely tailored, customized,
You got it.
personalized for each individual person.
You got it.
That's awesome. Okay. How long does a radiation session last?
Oh, so, it takes all those weeks to get things going, but the actual radiation treatment time is sometimes as little as 10 to 15 minutes.
Wow.
So I tell a lot of patients
quick.
that when they're coming for treatments, especially my breast cancer ladies that are fairly straightforward, they'll be in the department maybe 30 minutes, and that's coming in, waiting your turn, going to the back, getting in a gown, getting set up on the treatment machine. Their treatment's 10, 15 minutes, and then after that they get up, get dressed, and out the door and on with their day.
Wow. That is really quick. Let's see. What are the benefits of radiation therapy?
Sure. So it's a package deal with some of the different types of treatments that we do. A lot of times surgery is a mainstay for breast cancer, especially a localized breast cancer that hasn't traveled. And you can have some big surgeries like a mastectomy, but some women choose to have what's called a breast conserving surgery, where it's just a lumpectomy or a segmental mastectomy, where just a part of the tumor is completely removed, but just a portion of the breast around it is removed. A lot of times the risk for recurrence is a little bit higher in that situation, so it's a package deal. If you do a breast conserving surgery where we have remainder of natural breast behind, we'll do radiation to the breast afterwards, so that the risk of recurrence is not quite so high.
All right. Let's see. What can I expect after a radiation treatment? Are there side effects?
Oh, yes. So I tell all of my patients that radiation side effects is basically real estate. So what part of your body am I treating? That is the part that's going to have some side effects. With breast cancer and a lot of other types of our radiation to all parts of the body, people get tired. They get really fatigued. It's not a muscle weakness. It's just, I'm going to take a nap this afternoon, or I'm going to go to bed early tonight. So they just kind of get a little fatigued.
Okay.
So almost all radiation patients are going to get fatigued. But as far as the skin specific, when we're doing breast cancer, that's when you see a little bit of redness of the skin, a little bit of darkening of the skin, kind of like a suntan or a sunburn. Every once in a while you can have some skin breakdown. If that's the case, we've got some special prescriptions and burn creams that really seem to help, kind of helping people get through that skin process. And the skin changes aren't forever, they improve over time.
Okay.
So side effects, we talked about fatigue and skin reaction. Those are really the two big ones when breast cancer is the treatment, is the place that we're treating. But other parts can be affected. We talk a little bit about lymphedema sometimes with our breast cancer patients, and that gets into how much the lymph nodes are being affected. Lymph nodes sort of live in the armpit area, and they can also travel a little bit up towards your neck. And the first place that tumor cells in the breast tend to like to go is to those lymph nodes. So during surgery, when they take the tumor out, they'll also test some of the lymph nodes, and they'll make sure that there isn't tumor that has traveled outside of the breast. So when lymph nodes are removed at the time of surgery, they can't be there to actually work. And the lymph nodes in your armpit are used to kind of keep the blood flowing and the fluids flowing from your extremities. So when lymph nodes in your armpit aren't there because they were taken out at surgery, or they're not working because maybe tumor cells were in there, or maybe because they have radiation exposure, all those can contribute to getting some swelling because those lymph nodes aren't quite as functional. So when you have swelling of the arm, that's called lymphedema. So that's something that we actually look really hard for. So you'll come.
You guys actually have a lymphedema
We
team
sure
at Baptist
do.
Cancer Center, right?
We sure do.
I met them at Pink Ribbon Day last year.
Oh yes, they are great.
I learned all about it.
They are so good. They are physical therapists that are specialized in doing lymphedema screening and management. When our breast cancer patients are under treatment, and they're coming every day, because radiation is a daily treatment. We haven't talked about that yet.
Okay.
But it's a daily treatment, and so they're coming every day. But they see the nurses and the doctor at least once a week for an assessment. And during that assessment, our nurses are checking their arms and they're doing measurements. And they'll do a measurement kind of here between the wrist and the elbow, and right above the elbow. And they'll do both sides. So if they notice anything on that side we're treating that looks a little puffy, then we'll send them to our lymphedema specialist for an evaluation. And our lymphedema specialists have compression sleeves, wrapping techniques, massages, exercises, all sorts of things that they can do to either stop or even decrease that swelling that we see sometimes after radiation treatments.
Okay. So those are the main side effects. Or
Yeah,
things that
there's
can
always
happen.
a few more, but skin reaction fatigue are the big ones. We talk about lymphedema as being a risk. Long-term side effects, anytime you get radiation or anytime you get chemotherapy, you have a risk of something that we call a second malignancy, meaning that years from now, you have a risk of getting like a leukemia or a lymphoma or something because of all these toxic treatments you've had.
And is it true that the side effects are kind of slow to come on in the beginning? Is
You
that
got
right?
it.
Okay.
You got it. So I tell my ladies, you may be coming for 5 weeks at a time, but the first couple weeks, you're probably going to rock and roll and not have any problems. But then you'll start to see some of that tiredness set in. You'll start to see some of that skin change come in. And then once you're finished on the last day, they don't magically improve. They sort of linger for a few weeks, and then they get better. So it's offset by a couple weeks.
Okay. I'm going to take a few questions from our Facebook Live.
All right.
Let's see. And this one's actually about chemo, but I'm sure you can answer it. When does a person on chemo usually start losing their hair?
Oh, so that is a good question, and I think it's different. Now, some chemotherapies, you don't see hair loss. And with breast cancer, there's actually several different sort of types of systemic treatment that you can have. And this is getting a little bit outside of my specialty, so I'm going to let your medical oncologist tell you this for sure. But there's certainly cytotoxic chemotherapies that will cause some hair thinning and some hair loss. But there's also some hormonal therapies for our estrogen receptor positive breast cancers or our HER2 positive. Those sort of directed therapies are not nearly as bad about losing your hair loss. So there are some women who can get breast cancer treatments that don't necessarily lose their hair.
Okay.
Radiation doesn't make you lose your hair unless we do radiation to your head.
Okay.
Again, localized.
There's a difference for you.
There's a difference, yes.
Okay, Stephanie Watts asks, have you found cases where radiation will leave knots or masses or dark masses in the breast?
Okay, so yes, so theoretically, some of the skin changes can be permanent. We have a lot of tips during radiation treatments to keep your skin nice and moisturized. That tends to help that skin darkening and that skin redness from getting as bad as it potentially could as if you had just left it dry without any sort of conditioning. So if that's the case and you have extreme hyperpigmentation during radiation, I have seen those suntans stick around for a while. As far as the lumps and the masses, yes. So when you have a surgery like a lumpectomy and they take some of that tumor out and they have a tumor cavity that's left behind, sometimes we will actually target that cavity with additional radiation, thinking that where it started may be where it's most likely to come back. So sometimes having one section of the breast that's had a little boost and maybe not everything else makes it a little lumpy in comparison to the rest of the breast. But also radiation tends to make some fat necrosis, which is also a kind of a side effect of surgery and the radiation, where that natural fatty breast tissue just gets a little kind of necrotic. And that can feel a little lumpy to patients that have had surgery and had radiation. And sometimes those are very slow to sort of evolve.
Yeah.
They can stick around for a while.
Is it kind of like scar tissue?
Pretty much.
Okay.
Kind of like scar tissue.
All right. Good. Let's see. Cindy Cross says, how long after you finish radiation do you have to wait to get a scan to see if it worked?
Right. So that's a good question. So with breast cancer, we have screening mammograms, which is how a lot of times these are caught. But we also have what's called surveillance imaging. So once you have a breast cancer, especially if you continue to have natural breasts, you had a breast conserving surgery, you didn't have a mastectomy basically, we have to keep an eye on that breast tissue that's still there. So after you finish radiation, you're going to get on a schedule where you're getting at least yearly mammogram. That's according to the National Comprehensive Cancer Network guidelines. So every year you're going to be getting at least a year. Sometimes we get a little bit more conservative and we'll do every 6 months on that side that we have the cancer and we treat. But so that is going to be the schedule for that. So it's not necessarily want to make sure the radiation works. Because think about it, a lot of times with radiation, we're radiating after surgery. We're radiating after we hope all of the tumor cells are gone.
Right.
So we're not necessarily looking for anything left behind. We're looking for new things popping up.
Okay, good. And Susan McDonald would like to know, how often do women get a checkup after, how often maybe should a woman get a checkup after cervical cancer hysterectomy?
Okay, so cervical cancer can be treated lots of different ways. Very, very, very early stage cervical cancer can have a hysterectomy, in which case you need to be following up with either, ideally probably a gynonc, which is a specialized gynecologist in oncology, gynecology. So you want to be following with them, kind of along their schedule. A lot of times it'll be doing pap smears and vaginal pelvic exams every 3 to 6 months, but at the very least, your regular gynecologist is going to be doing pap smears probably pretty regularly, at least every 6 months, I would say, after a cervical cancer hysterectomy treatment. Hysterectomy means to surgically remove the uterus and part of the vaginal cuff. Most of the time, cervical cancer is treated, more advanced cervical cancers are treated with chemotherapy and radiation and not surgery. It's the same thing. Once you're done with your treatments, you're going to get onto a surveillance schedule, usually with a gynecologist, oncologist, with pap smears pretty regularly to make sure there's nothing growing back.
Okay.
Yeah.
Good.
Got a little outside of the breast zone.
Yeah,
That's okay.
Yeah. Great. It's good that you treat all areas.
I do.
We are talking about breast cancer today, but you can still ask Dr. Suggs. All right, we're going to go back to our questions from the Ask the Experts page. Are there different types of radiation therapy?
Yes, so there are. So the main ones that you'll get in Mississippi, let's just say, are going to be electrons and photons. So they act a little bit differently on the kind of molecular level. They're both going to cause the same sort of damage to the cells. They're going to have the same effect. The biggest difference between photons and electrons is how deep can they go. Photons can pass through most of the body tissue, whereas electrons, once they hit your skin tissue, they start to fizzle out. So electrons are great for treating very shallow things. So we use that a lot of times for like a scar boost after a mastectomy. But photons will pass through some of that dense breast tissue to get a good, even dose all over the breast.
Okay. Wow. All right. Which radiation techniques are most effective and most commonly recommended?
Sure. So what we talk about, external beam radiation, that's the photons and the electrons. Those are the most commonly recommended. As far as duration of treatments, that's actually getting into some of the kind of new ways that we're advancing some of the breast cancer treatment these days. So I say old school, but traditional standard radiation of the breast is usually about 5 to 5.5 weeks of daily treatments where we treat the entire breast. Again, it's a 15-minute treatment. It interrupts your day just a little bit, but it does take up quite a bit of your calendar when you're there for 5 weeks. And then you talk about getting a boost to the scar, a boost to the lumpectomy cavity for an additional week. You're looking at, sometimes 6.5 weeks of treatment. There are some thoughts that you can maybe go a little bit faster each day and get a little bit higher dose of radiation each day, and then try to be done in a shorter number of calendar days. So we call that hypofractionation. Okay. And so that's looking at, between 3.5 to 4.5 weeks of treatment as opposed to 5.5 or 6. A lot of times that's a great option, but we really tailor those short treatments to patients that have small tumors, no lymph nodes that were involved, don't have to have chemo, and they're not too young. So we really want to do sort of standard of care with some of our little bit more aggressive looking cancer situations, but for those that are really early stage, it's sometimes a very nice option.
Okay. Is everyone with breast cancer able to get radiation therapy?
Sure, anybody can get radiation. The question is, should you?
Okay.
So when we talk again about the breast conserving surgery, when they just take the tumor out and leave the natural breast behind, then we certainly want to do radiation therapy in almost every case. Now, if someone is very elderly or very sick with a lot of other comorbidities, a lot of other medical problems, and life expectancy and generally may not be 5-10 years, then we can sometimes consider maybe radiation's not needed if we have really good surgical margins. But again, that is a very rare case. Most of the time, breast conserving surgery and radiation therapy are going to be a package deal. Now, sometimes you can avoid radiation by having just the bigger surgery, meaning mastectomy, where all of the natural breast tissue is removed on that side that's affected. And most of the time in that situation, going into it, or you expect going into it, that having that bigger surgery is maybe going to keep you from having to get radiation. There are some instances where tumors may be very large or there's lymph nodes involved and then we weren't expecting that. Then we want to talk about maybe radiation after even a mastectomy might be beneficial as far as keeping it from coming back. But certainly, radiation, works hand in hand with, our surgeons and our chemo doctors to kind of give everyone a tailored approach that's best for them and their tumor.
Okay. Let's see. Lisa Coates on our Facebook page says, what are the symptoms of breast cancer? I've heard that the lumps are hard.
Okay, so there are lots of women that find their breast cancers themselves, and they are taking a shower or they are doing something else and they happen to notice something feels different. One story we hear at least probably once a year is something happened. I tripped and I hit on the corner of the cabinets, or something like a trauma, and all of a sudden they feel something. Well, that's probably just very serendipitous that you happen to feel it. But unfortunately, most of the time, breast tumors, especially those that we want to catch early, are not going to be palpable, which makes it very important for screening mammograms and getting those to make sure that we're catching something as early as we possibly can. Oftentimes when you feel something, it's already in a higher stage, because just by virtue of you being able to feel it means it's bigger.
Okay. And as far as you mentioned mammograms, what age is it? Well, it's 40 when you should get them regularly, but if you have a familial history, you should start earlier than that?
You got it. So, the current guidelines, and people argue this, but we'll save those arguments for another day. But for the most part, women that are aged 40 are going to be recommended to get screening mammograms. From age 45, you certainly are going to be getting yearly screening mammograms. Many women are getting them earlier at age 35 just because of family history, or sometimes there's some genetic things that we know are in maybe first-degree relatives. If you've ever had radiation to the chest before, many Hodgkin's lymphoma, pediatric patients, things like that, those can leave you a higher risk of getting breast cancer. So we're going to start screening you a little bit earlier. I think most probably people here in town in the state are getting screened about 35 and up.
Okay, yeah. And is it true, I'm going to ask a question myself, is it true if women don't breastfeed with their first pregnancy, are they more susceptible to getting breast cancer? I've read that somewhere before.
So there is a protective factor for breastfeeding, and some of the data says a year or year and a half or 2 years, and the longer you can breastfeed, the more natural protective that is for breast cancer. Now, that's not to say that just because you breastfeed, you're not going to get cancer.
Right.
And also, of course, there are many people that are getting breast cancer that actually did breastfeed. So it's not an all-in-one, but there is a protective factor for breast feeding. And 1 year tends to be the mark, and that's cumulative. So if you have 3 children and you breastfeed for 4 months each, that counts.
Okay.
But as far as just because you didn't do it with the first one, I think you can still get that protective factor if it's child 2, 3, or 4.
Okay. All right. Let's see. What are the different types of breast cancer, and are they treated differently?
Sure. So you can sort of look at breast cancer divided up many different ways. One of the ways you can do it is male and female. Those are often treated very similarly. Another way you can do it is whether it's a ductal carcinoma or maybe a lobular carcinoma, and all that means is that they started in different places in the breast, whether it's the actual glands that make milk or if it's in the ducts that transport the milk. So that's another way that you can sort of divide them up. Those are treated very similarly. You can look at sort of how these tumors can be molecularly different. So we talk about hormone receptors, whether they're positive or negative. So we're talking specifically about estrogen receptor and progesterone receptor. When those are positive, we think that those are driven by the fact that there's estrogen in your body, which is what women tend to have. So there are ways that we can block some of those signals that are used to make those tumors stimulated to grow, and so we can stop those with hormonal medications. But there's also some others. HER2 is another one. If HER2 is positive, that opens you up to a whole category of medications that you can use to prevent recurrence. And of course, you hear triple negative. What that means is that they're ER negative, PR negative, and HER2 negative. So again, those tend to be a little bit more aggressive, and you don't have the hormonal medicines. You don't have the HER2-based medicines that you can use as another kind of crutch to keep this from coming back.
Okay. I'm going to read Sarah Broadway's comment. She says, "My breast cancer was found on my mammogram at my yearly checkup. The mass could not be felt by me or my doctor. Get your mammogram," with lots of exclamation marks.
Absolutely. I will agree with you 100%.
Yes.
Thank you for commenting.
And you guys partner with Fund for the Girls. Can you tell us about that?
So Fund for the Girls, I'm really excited about. At Baptist, there are sometimes financial limitations for women getting their mammograms. They're expensive. I think the cash price at Baptist is $180, which is not cheap, but it's certainly more affordable than sometimes other places. So they have this sort of packaged discounted price of $180, but also there is something called Fund for the Girls. And what that is if your Baptist physician says you need a mammogram and you say can't afford it, don't have insurance, or have a really high deductible, there is a support program in place that your doctor can apply you for to see if your mammogram can be covered.
Okay.
Yep.
So price is not a factor, not an excuse for not getting your mammogram.
Absolutely.
Fund for the Girls at Baptist.
Yes.
All right. Back to questions from the Ask the Experts page.
Okay.
Are there cancer support groups that you would recommend?
Oh, absolutely. So American Cancer Society is a big one, and they've got a lot of things here in town. Specifically at Baptist, we actually have a couple of great things. So we actually have what's called a cancer navigator, and that is the person that's assigned to you for whatever questions you have. If you're like, hey, am I supposed to be seeing my surgeon sometime soon? Or hey, wasn't I supposed to go see my medical oncologist? They will navigate you to wherever you're supposed to go. And they're sort of your point person to help you figure it out, because you're going to get so much information, especially if ladies that are getting surgery and chemo and radiation. There's so much information they'll get all at once. This is someone that can help them fine-tune, okay, this is what we're going to do next, sort of help them lay out a plan. So our cancer navigators at Baptist are just amazing. So we're really, really, really grateful to have those. The other thing that we do at Baptist is we have an orientation. So I think it's twice a week. Any cancer patient and their families can have an orientation where they meet some of the people from each of those different subspecialties to see what services are available. The other thing Baptist has is we've got chaplains. I love working for Baptist because I can pray with my patients and nobody gets me in trouble for that.
Awesome.
But we have chaplains that are there for spiritual support. And then we have an oncology counselor who's a PhD psychologist. And so he is available for stress screening or smoking cessation or any other things that sort of just, great little psychological pep talk is good for.
Yeah.
So we have all these different sort of things. Oh, and a dietitian. We've got a great dietitian. And so she's helpful, because it's, trying to get to a good healthy BMI is one of the only, one of the few modifiable things that you can do after breast cancer to help your recurrence risk go down. So we just have all these people in place that can really help with trying to just make it easier.
It's like they're all truly there to hold your hand through the entire process.
You got it.
And I met and actually interviewed some of your cancer navigators last year, and that's really their function, to hold people's hand, literally.
Absolutely. And I'll tell you, they're going to hold my hand too, because they are so grateful. I can go up to them and I say, guys, this person lives an hour and a half away, and they're like, we'll find them housing. Don't worry, we can do that. So,
and some of them have been through it themselves and can share that experience with patients.
Themselves and their family members, absolutely.
That's great. Okay, how do you prevent radiation from affecting normal, non-affected tissues?
Sure, so that's a very good question. So radiation, again, is a targeted, directed therapy. So we want it to go, for instance, after a breast-conserving surgery, we want it to go through the remainder of the breast, but we want to avoid everything else. We want to avoid the heart, the lungs, the spinal cord, all those things that are inside. One of the ways that we do that with breast cancer is we actually use physics, and we say, okay, we're going to direct the radiation beam so that it will skim the chest wall and treat everything on the outside, but not turn it and direct it towards anything on the inside. There are other ways that we can do that by modifying sort of the fluency of the radiation, where it's a little hotter here, a little colder here, and basically kind of paint a good radiation dose over where we want it to go. And then, of course, once you get your treatments, we're actually checking at least once a week, if not more, to make sure that you're in the right spot. So you have skin markings. That's what my ladies love. When you come in for your CT scan, they put a little crosshairs in a couple of places on your chest so that they can line you up on the treatment machine. Sometimes those crosshairs get a little big, and sometimes my therapists like to get a little crazy with their artwork, and so you'll see sometimes some squares right here in this. So I just tell them, they're just leaving you a little color in the lines for your lotion and your moisturizer. But yeah, so we're doing x-rays every day. So we line them up on those skin marks. We're doing x-rays. So we're making sure that we're very careful, because again, once you get radiation, we can't take it back.
Okay. We've got quite a bit of questions coming in on the Facebook Live. I'll get to you in just a moment. I want to let you follow up with this next question. It's how many radiation therapies are typically prescribed?
Sure. So we talked a little bit about that earlier, but standard is 5.5 to 6.5 weeks of treatment. The hypofractionated, that short course, is between 3.5 to 4.5 weeks. There are some that are a little bit quicker. They're not quite as mainstream. Not a lot of places are doing those. One of them is an intraoperative radiation, which means at the time of surgery, they'll do the lumpectomy, then they'll do a little radiation boost just to the cavity. And as long as everything at the time of pathology looks okay, sometimes they'll say that's enough. Some of the studies looking into that aren't quite as robust and aren't quite as, the long-term results aren't quite as good. I mean, the recurrence rates are low, but they can be a little lower with some of our techniques, so that's not quite as popular. Okay. There's actually something called intracavitary brachytherapy, which really gets a little technical, and instead of treating the entire breast, we treat just that lumpectomy cavity. And the way that we do that is with a radiation applicator device. And a lot of times it looks like a lollipop, like a little balloon on a catheter on a stick. And that balloon would be put in by your surgeon at the time of lumpectomy or shortly thereafter. And it's sutured into place, so you kind of walk around for a week or so with that coming out of your skin, and it's fine. We do antibiotics and things like that to keep it from getting infected. It does make it a little bit hard to sleep at night sometimes because you have to lay on your back. Yeah. But what happens is after that catheter is in place, we'll do a CT scan, and we'll say, okay, this is the measurements of the lumpectomy cavity around that little lollipop balloon, and we can say, okay, this is where a radioactive source can come out of our treatment machine. And it will go through that straw, the tip of the lollipop basically, and it'll go and sit inside that balloon. It doesn't touch your skin, but it's close enough by that the radiation is emitted and it treats that lumpectomy cavity. And so at the end of your treatment, it'll come out. Now those treatments are maybe 15, 20 minutes at the most.
Okay.
You get those twice a day for a week, so you get 10 treatments. And so that's one way that we can also treat and get you done a little bit quicker. There's some ladies that live really far off in the Delta, and they want to come to Jackson for their treatments, and they don't want to be here for even 3.5 weeks. They want to be here for a week, and so that's something that's an option.
Okay. Let's see. Okay. We have, well, we got that one already. Okay. This one's not about breast cancer,
Okay.
but Sherry Lacey says, does every woman that has had a full hysterectomy need hormone replacement therapy? Which that's not actually a
Okay. So
oncology question.
well, a little bit. So, and
Okay.
it does kind of tend into get to back to your breast cancer. So we'll talk about that. So,
Okay.
when she's talking, I'm assuming a full hysterectomy, meaning that uterus is removed with the ovaries. If you're postmenopausal and your ovaries aren't really doing much for you anyway, then you're not going to notice much of a change. But for maybe people that are perimenopausal, or certainly if you're premenopausal, when you remove the ovaries, your most of the source of estrogen, then you're going to start having hot flashes, night sweats, menopausal symptoms, and those can be quite uncomfortable. So many times people will consider doing hormone replacement therapy for that, basically replacing the estrogen that is not there in your body. The thing about estrogen replacement is that we talk about breast cancer as being a little bit of an estrogen-driven tumor. So sometimes prolonged hormone replacement therapy for years and years can increase your risk of having a breast cancer. So the answer to that question is, if you're having bad symptoms after hysterectomy, then you need to talk to your doctor about the risks of doing hormone replacement therapy. And if you decide you want to do that, do the littlest amount of hormone replacement therapy that you need that helps your symptoms better, and do it for the shortest amount of time possible. So
Okay.
really just trying to get back to kind of the natural way of your body working.
All right.
Yeah.
Iva Rigby says, is there a blood test to determine if one is in remission from multiple myeloma?
Right. So multiple myeloma is one of the other types of cancers that we sometimes treat. That's mostly a systemic treatment with your medical oncologist. There are certain things that if they are positive at the time of diagnosis, they can be trended in your blood. But as far as a specific answer, I'm going to say you're going to have to talk to your medical oncologist about what, because again, that's a personalized question based on kind of how your myeloma presents.
Okay. And Tim Modern asked us to please answer Iva because they have the same question, as I have had 14 operations from 2015 to present. They have me coming back every 6 months for more tests, not one time a year. So same with him. He probably needs to see his oncologist.
I would think so. I don't remember what question Iva had about.
The one you just answered about the myeloma. multiple
Oh,
myeloma.
the blood. Okay, yes. So the thing about myeloma is, years and years ago, we didn't have some of the great drugs that we had, and so it was not a great diagnosis to get. But now that we've got some of these new medications, we're seeing really long survival. But we always have to monitor for surveillance imaging and blood work, and a lot of times when I'm treating a multiple myeloma, I'm treating for one of two reasons. There's one spot that's found, and we really want to treat it and try to keep it from going anywhere else. But most of the time with multiple myeloma, when I'm doing radiation, I'm sort of a spot welder. If there's a spot here that's causing problems, I'm going to radiate that, help you feel better, get you back in so that you're strong enough to finish your systemic treatment.
Okay.
But yeah, that's certainly a great question for your medical oncologist. Sorry, that's sort of a cop-out.
Lisa Coates says, can you talk about the fibrocystic breast?
Sure. So a couple of things about breast tissue and density. Sometimes it's very challenging with the mammogram to be able to see small changes or small calcifications from tumor based on if your breast is very dense. There are some parts of the natural breast that are fine, and they're going to see those on a mammogram, and they may put an ultrasound on there just to make sure it looks like it's a benign thing. But some of these changes are a little bit, sometimes we say, okay, look, we need to follow that a little closely, make sure it's not going to cause a problem down the road. But fibrocystic is very common. That's a lot of times when, especially maybe younger women that are still having menstrual cycles, will say, look, I have this lump, and it comes and it goes and it comes and it goes, and they're worried, and sometimes it'll be one of these sort of normal variants of the breast. But yeah, it's unfortunately, you still have to get those checked out.
Sure. We're starting to run low on time here, but we're going to try to get to all the questions, the questions that we can.
Sure.
Back to question from the Ask the Experts page. How do you decide if you will treat the whole breast or partial breast for radiation treatment?
Sure. So that partial breast, like we talked about with the catheter, the intracavitary brachytherapy, a lot of times we'll do that if it's a very low-grade tumor, if it's a very small tumor, if the surgical margins were really good, if our patients maybe a little bit older, has a lot of other medical problems, and we want to get things done a little bit quicker. Those are times that we'll think about doing just that partial breast irradiation. Most of the time, if it's maybe a little bit on the larger side of a tumor, or if the margins aren't quite good, then that's when we're looking at treating the whole breast. Most women are going to get whole breast radiation just because we really want to give you the benefit of treating as much of that territory as we can to keep it from coming back.
Okay. Last time we spoke, we were talking about this sort of thing, and you mentioned the term cosmesis. Can you talk about that a little bit?
Yes. Okay. So cosmesis, I tell everyone that's the fancy word for how symmetric and natural do your breasts look. Well, if you have two breasts that are perfectly symmetrical at the beginning of this process, and then one has surgery and one has radiation, then you're going to notice some differences over time between those two. Surgical, they're going to remove some of the volumes. You sometimes have a little volume loss so that there's asymmetry. Radiation also tends to change the way that the breast tissue is. It makes it a little bit maybe firmer. Makes the skin a little bit tighter or thicker. Sometimes makes that breast kind of sit up a little bit higher than the contralateral breast that hasn't had radiation. So I tell people that cosmesis is over time how natural and symmetric are the breasts. Are they going to be perfectly symmetrical? Probably not. Are they perfectly symmetrical from the get-go? Most of the time, no. So many women just, they don't mind, and they understand that there's going to be differences because one of them had this treatment or not.
Right.
But that's when our colleagues in plastic surgery come into hand, because if you've got some volume loss from a surgery, or you've had a mastectomy and you want reconstruction, or you want them to match at the end, you want to improve your cosmesis, we have some really great plastic surgeons that are just really good at making these women feel happy again.
Okay, good. That was the next question. So have someone gone through radiation or a double mastectomy, was plastic surgery still an option for them?
Absolutely. Now, the plastic surgeons love to get finished with their sort of expansion process before radiation, and that's fine, and we tend to try to, accommodate that whenever we can. The thing about skin and whether it likes to expand or not is, radiation kind of makes that skin a little tough, and it makes it want to try to scar down a little bit towards that flat chest wall. So it makes it a little bit harder on my plastic surgeons when you had radiation. So a lot of times they like to go ahead and be finished with the expansion process before I get radiation. And usually when someone has reconstruction after mastectomy, of course there's several options of the way those can be done, but one way is common is to put in an expander, and that's just kind of like this empty space that they put in between the skin and the chest wall, and then over time they'll inject some saline, and it'll get nice and sturdy, and it'll help to kind of plump up that skin into the shape of a breast. And then over time they would replace that expander, which is kind of hard and solid, into something more natural feeling like an implant. Usually if that's the case and they're getting radiation, we'll do the expander first, we'll do the radiation, we'll leave the expander in a little bit longer after radiation's over, just to let that skin kind of have time to get to where it's going to be and happy and not trying to scar down and get back towards the chest wall again. And then we'll change it out for the implant.
Okay, good. So it's not a big deal if someone decides, go ahead, remove them, because they're faced with cancer. I'm sure they're very worried. They just want to get that taken care of. But then after the fact, they may not feel the same after not having their breasts. So good to know. Are there any issues with having breast implants after having cancer? Because some cancers return, right?
Right. Okay. So there's a lot of people are concerned, and they hear stories that implants can cause cancer. Well, there's a certain type of implant that can cause a certain type of lymphoma that we don't see that often. But the issue with having implants is really we want to make sure you're getting a good mammogram. We want to make sure that that implant's not hiding anything. And so there are ways that we can do the mammogram that sort of move that the implant out of the way so they can get a better look at the tissue. We just want to make sure that if you're getting your imaging, that you're getting a good quality image, even with that implant in place. So I actually say that that's not a problem at all.
Okay, so I'm going to double up on the next two questions here since we're running out of time. They kind of go together. Can I work while I go have my radiation treatments, and what precautions should I take while on treatment?
Sure. Okay. So a lot of times with chemotherapy, people are going to say, like, look, don't go out during flu season. Don't go to the doctor just for a well check because your immune system may be down a little bit from the chemotherapy. Radiation, that's not so much of an issue. So the big precautions I tell my ladies is, you got to avoid the sun. That whole skin and kind of that breast chest wall and over in the armpit area is going to get a little tender. So we really want you to sort of baby that area. So don't go out in your bikini and float on the reservoir. Keep it covered up in the sunshine. If you're a tennis player, like, maybe take it easy for a couple weeks so you don't get skin on skin rubbing there in that side of your arm. But so really the precautions are, go and do your normal routine. That sometimes helps with the fatigue. If you're kind of going and doing and keeping up with your work schedule, you don't notice the fatigue quite as much. But as far as limitations, a lot of women are still working during treatments. They're certainly, taking care of their families. Now, all that to say, if you have cancer and you're tired and tuckered out and need a break, take a break. Everyone is different, so you don't, there's no expectations. But a lot of times people are able to just kind of keep on going.
Okay. And I have a strong family history of breast cancer. What are my chances of getting another cancer, and does that change my treatment options?
Okay. So sort of maybe a meld of two questions there. So if you have a family history of breast cancer, you're going to want to talk to your doctor about it. You're going to want to make sure that you're screening appropriately. So if your mom had cancer at 40, you need to be getting mammograms by 35 or even earlier. So you just want your primary care physician to know kind of what your history is so that you can be screened appropriately. The other thing is kind of the way that was maybe worded is if you've had a cancer before, what are your chances of having a cancer again? Well, you know, any medical student can tell you the risk of having cancer is having a cancer before.
Right.
Just having that sort of environment that your body had a cell that was supposed to do something and didn't and misbehaved and somehow didn't get taken out by the immune police cells of your body. So
Yeah.
if you have that sort of tendency, then yes, you can certainly have more cancers again. And that's where cancer survivorship comes into play, which is really great because these breast cancer ladies, we're living years and years and we're doing well. And so now we got to make sure that we're following up and making sure that everything else is cared for. You know, getting your mammograms, but hey, let's get your pap smears too. Let's do all these other things for screening.
Okay. How can our viewers find out more about you and Baptist Cancer Center?
Sure. So they can come to our baptistcancercenter.com or they can call our phone number. It's 601-968-1049.
Okay. Now, in October, that's Breast Cancer Awareness Month, and we do our Power of Pink. Baptist is a big supporter and sponsor of Power of Pink. We are going to pink out the hub. Our logo is going to turn pink. We're going to have pink balloons, and that is when, I guess, Dr. Suggs, you may come back, or one of your colleagues, y'all will be back in October.
Yes.
Okay, so you can submit your questions for Dr. Suggs or any of the doctors at Baptist Cancer Center via our Ask the Experts page on WLBT.com. You can see our live schedule, upcoming schedules, and questions for other experts too. Thank you so much for coming in today.
Thank you for having me.
Gave us some definitely expert great information for everyone. Thank you all for your questions. Thank you for watching WLBT's Ask the Experts.